Hey everyone, it's Sarah with RegisteredNurseRN.com, and in this video I'm going to be going over ventricular septal defects. And this video is part of an NCLEX review series over pediatric nursing. And as always, after you watch this YouTube video, you can access the free quiz that will test you on this condition. So let's get started. What is this condition? Also called VSD. It is a congenital heart defect that occurs when a hole forms in the ventricular septum. So there should never be a hole in the septum that separates your ventricles. And we're talking about the right ventricle and the left ventricle. And here in this drawing, you can see a big gaping hole in between those ventricles. And what's that going to do? It's going to alter blood flow. It's going to create this left to right shunt of blood. So blood in the left side of the heart is going to be shunted. It's going to flow to the right side of the heart. Now, when that happens, we're going to have issues, especially if this is a large hole in the heart. It's going to cause increased lung blood flow because you're going to have all this blood from the left side shunting over here to the right side, plus you have all this blood already entering in through your inferior and superior vena cava, and it's going to be shot up through the pulmonary artery to the lungs, and the lungs cannot handle all that blood volume. It's going to affect them, and in turn, it's going to affect the heart. And when we talk about the pathophysiology of this condition, you will see why. Now let's talk about some quick facts about VSDs. Okay, according to cdc.gov, 1 in every 240 babies born in the United States each year will have a ventricular septal defect. And there's various types of VSDs. There's 4 different types that we're going to talk about. And patients can have multiple holes within this septum. They don't have to just have one. And they can have various sizes, like small, moderate, or large. And these holes can affect different layers of the septum. So the first type we're going to talk about is called membranous. And these holes are found in the upper section of that septum. So about right in this area. And they tend to be found close to the tricuspid valve, which is found over here on the right side of the heart in between the right atrium and the right ventricle, or over where the aortic valve is on the left side of the heart coming off of the left ventricle. And when these holes get close to these valves, they can damage them. So they can have issues with their valves. A lot of patients with VSDs, especially larger ones, they can have what's called aortic valve regurgitation, where that valve is not closing properly and blood is really backflowing from that valve, hence regurgitation. Another type is a muscular VSD, and these are holes that are found in this lower section of the septum. Now, one thing to remember about these muscular VSDs is that if they are small, they tend to have a high probability of closing on their own, so self-closure. Another type is outlet VSD. These are also called conal or subarterial VSDs, and just as the name says, outlet, these holes are going to be found close to structures where blood is leaving the heart. So those structures would include like the pulmonic valve and the aortic valve, because that's where blood leaves the heart. It leaves the right side over here through the pulmonic valve to go to the lungs, and then it leads through the aortic valve, the blood, to go through the body. And these VSDs tend to be rare, but they can occur. The fourth type is an inlet VSD, and it's really the opposite of the outlet because it's found near structures where blood is entering into the heart. So it would be found where the tricuspid valve is, or the bicuspid. Bicuspid's also known as the mitral valve. Now, as I said before, small VSDs, a lot of times they are monitored and they tend to close all by themselves within that first year of life. So the physician, nurse, they may hear a heart murmur, they monitor that with an echocardiogram, which is like an ultrasound of the heart, and they can look at that. But with large VSDs, they will definitely need to be monitored, and they will usually be started on medications, because what happens with this condition is you get heart failure. So they'll be started on medications to help with the contraction of the heart, make it stronger but slower, like digoxin, diuretics to help with all this fluid that is backing up within the lungs, and ACE inhibitors to help lower that pressure and lower the workload on the heart. And we'll be talking more about those in our nursing interventions. Also, they will need repair usually to close that large hole in that septum. Now let's talk about the pathophysiology of a ventricular septal defect. And as I'm talking about this patho and the complications that arise from these defects, what I'm talking about are these large holes that exist in this septum, because the large holes allow more blood to be shunted from that left side to that right side rather than a small one. So to understand VSDs, you first have to understand the normal blood flow of the heart. So I'm going to quickly review that, and then I'm going to show you what's going on with the VSD, and you'll see the difference. Okay. So with normal blood flow of the heart, everything starts on the right side of the heart. And the goal of the right side is to get unoxygenated blood to the lungs. So it's going to take it right to the lungs. So blood enters in through your superior and inferior vena cava. It flows down into the right atrium. Then it goes down through the tricuspid valve, which opens up and allows it to flow down to the right ventricle. And normally, in a normal heart without a hole, there is no connection between the right and left ventricle. So the right ventricle will contract, it will shoot the blood up through the pulmonic valve, through the pulmonary artery, which is going to take it right to the lungs, and the lungs is going to do its job and oxygenate that blood. So now the blood is oxygenated, it's going to enter in through the left side of the heart. So the blood has left the lungs to go to the left side of the heart. Through the pulmonary vein, it's going to flow down through the left atrium, then down through the bicuspid, also called the mitral valve, into the left ventricle. And the left ventricle is very strong because it has to be strong in order to pump that fresh oxygenated blood up through the body into the system. So it has to generate a lot of pressure. There's more pressure on the left side of the heart than there is the right side of the heart. So that blood is pumped up through the aortic valve, then through the aorta, and all through your body. Now let's talk about the blood flow in a patient who has a large VSD, so a large hole in this septum. So blood is going to enter into the heart just like it normally would in a heart without a hole in the septum. It's going to flow down through the right atrium, the right ventricle. But now we have a connection between our right ventricle and our left ventricle, and that is where our issue is going to cause problems. Now we just learned that the pressure in the left side of the heart is a lot more than the pressure on the right side of the heart. So that is why we have a left to right shunt, because that left side needs more pressure in it to get that oxygenated blood to the body compared to the right side. The right side just has to get it to the lungs. So we have all this blood that's already really been on the right side of the heart, in a sense recycling and coming over to the right ventricle. Then you have all this blood that's coming from the circulation that's exhausted, needs to be oxygenated in the right ventricle. So you have like extra blood volume that this right ventricle has to pump, that it's not really created to pump that much blood to the lungs. So the right ventricle over time is going to enlarge. So it's pumping all this extra blood to the lungs. Now the lungs definitely cannot handle this increased blood flow. And over time, what's going to happen, you're going to have pressure increasing, and the arteries that feed the lungs are going to become damaged, and they're actually going to narrow. So you're going to get a condition called pulmonary hypertension, and this is going to cause that infant, that child, a lot of issues, a lot of breathing issues, and it's going to cause issues on their heart because the right ventricle is already exhausted from having to pump extra blood volume. Now, when this pulmonary hypertension occurs, we have narrowing of arteries, this heart has to pump even harder to squeeze that blood to the lungs. It's like the same concept with a water hose. You narrow that water hose in order for that water to get it through the water hose to the other end. It's really got to increase its exertion and its pressure to get that water through that narrow little hose. And that's what's happening. So that's going to cause even more problems, and that's going to stress the heart out, and we're going to get heart failure. So here you have this infant who has heart failure, and the parent usually will notice signs and symptoms about 1 to 3 months after birth. And they'll have difficulty feeding because it takes a lot of energy to eat. Because they have to suck on that bottle and their energy is expiring because their heart can't keep up because it's so weak. So they don't finish those feedings. And it burns a lot of energy having to breathe, having to pump this heart. So they're burning extra calories, they're not feeding to take in that caloric intake. So they start to lose weight and their growth is affected. In addition, they can start to get a lot of lung infections because you are getting all this congestion where fluid is backflowing into the lungs from where this heart is weak, the heart failure, and they're at risk for more infections. In addition, they can start to have dysrhythmias where atrial fibrillation, where their heart electrical activity is not working right, and they're at risk for valve issues, like I said earlier, regurgitation of those valves, and they can have endocarditis. They're at risk for developing infection within the heart because the lining in the heart can be disrupted because of what's going on, and bacteria can stick in there and cause infection. Now, what if this VSD is never repaired and they have this continuous left to right shunting, the overflow of the blood going to the lungs, stressing the lungs out, stressing the ventricle out, all this? What's going to happen? Well, if this is left untreated, the patient can develop what's called Eisenmengers Syndrome, and this is where you have a reversal of that shunting. So what's going to happen due to that extensive pulmonary hypertension that has happened? What will happen is that you will actually have a reversal of shunting of blood that will go right to left. So instead of going left to right, this blood will actually start to now flow into the left ventricle. So you won't have the shunting anymore of the oxygenated blood going into the right ventricle, but you'll have the unoxygenated blood going into the left ventricle, and that's going to cause some issues. What's going to happen is now you're going to have this unoxygenated blood that didn't make it to the lungs to get oxygenated go back into circulation, and the patient will start having cyanosis, bluish tinting color of the skin, low oxygen in the body because it didn't get oxygenated. It's going back through circulation, and you can start to see clubbing of the fingers and things like that. And this condition is irreversible. They will usually need a heart or lung transplant. So really, patients need to get treatment for this so that does not occur. Now let's talk about signs and symptoms of a VSD. Okay, when are you going to start to see signs and symptoms in the pediatric patient, in that infant who has like a VSD, like a large VSD, because those are really the ones that cause our signs and symptoms? Well, you're not really going to see it immediately on birth. You may hear like a heart murmur, but that infant is going to start showing those signs and symptoms of that heart failure, pulmonary hypertension, about 1 to 3 months after birth. Now, why is that? Okay, well, in utero, when the baby is in their mama's belly, that pressure in the right side and the left side is equal because their lungs aren't working yet. But once they are born, they start breathing on their own. Things are going to start changing in the heart, the pressure specifically. The pressure on the right side of the heart is going to start to decrease. So if they do have this large gaping hole in their septum, as that pressure starts to decrease over time, which is about 2 to 3 weeks, you're going to start seeing this shunting of blood because the pressure will be decreasing on the right side compared to that high pressure in the left side. So around 1 to 3 months, once that pressure has stabilized, it's decreased on the right side, that left side will start shunting that blood over to the right side, and that's going to increase that blood volume going to the lungs, leading to pulmonary hypertension, heart failure, and the parent may bring their baby in for those checkups, report baby's not feeding right, they get really tired, fatigued easily, The weights aren't really looking good for that child based on its age. They could start having frequent lung infections, all pointing to a sign that, hey, this baby may have a congenital heart defect. We need to do an echocardiogram and see what's going on. So to help us remember the signs and the symptoms, let's remember the word hole in the ventricles. That is what is going on. So what we're going to do is sum up everything we went over, and that's our signs and symptoms. So H is heart failure. We talked about why there is heart failure going on and the pulmonary hypertension. So the signs and symptoms you're going to see is they're going to have difficulty breathing with all the fluid congestion from where that heart is weak in there and fluid's backing up. They're going to fatigue with ease, especially with any activity, feeding, swelling in the hands, the extremities where the fluid is building up, crackles in the lungs from the congestion of fluid, and they can have sweating with any type of activity. Like a lot of parents report while they're feeding, they may get really sweaty, be cold and clammy. O for often experiences lung infections, and that goes back to the congested lungs from where they have all that fluid in there. And L for low growth weight, loss of weight, and that ties back to their heart and breathing, burning a lot of energy to maintain life for that child. That can burn a lot of energy. They're not eating like they should because they're just exhausted from where their little heart is just exhausted and they can't stay awake to continue and they're just exhausted. Next is E for extra heart sounds, and a heart murmur may be detected in VSD. You may hear it at birth. It really depends because why are you even hearing a heart murmur? What's it from? Well, what it's from is that you have this flow of blood from the left ventricle to the right ventricle. So you're hearing that turbulent gradient of that blood crossing over during systole. And depending on the pressure changes that's occurring in that infant, you may or may not detect it because remember the pressure changes over the next 2 to 3 weeks. Now the term of the murmur is holosystolic or pansystolic murmur, and this means that you're usually going to hear it starting at S1 and it'll extend into S2. And it can be found in the left lower sternal border. And what's interesting is that smaller VSDs, those small holes, can actually produce a louder murmur than compared to a large one. And think about it. If you blow through a really small hole, you can actually hear the noise. It's a lot louder than if you blow through a big large hole. So that's where that's from. Now let's talk about nursing interventions and treatments for a patient with a VSD. A big thing that is done is that, of course, the VSD will be monitored and medications will be ordered, especially for those large ones, because the doctor wants to prevent that patient from developing heart failure, pulmonary hypertension, and going into the Eisenmengers Syndrome, which is irreversible. So they can give them medications and, of course, surgical repair. So as a nurse, you want to be familiar with some of these meds. One med they can give is called digoxin. And what does digoxin do? Well, it helps the heart contract stronger and it slows it down, which is perfect for this infant's heart because it's exhausted and it's been really just pumping away and it's weak. So digoxin can make it stronger but pump slower, but you have to watch this drug. It's a great drug, but if it gets where it's not in therapeutic range, it can cause toxicity and death. So what you have to do is you have to, before you give it, you monitor and record the apical pulse for 1 full minute. And depending on what that pulse is, you may or may not give the medication. And you'll always follow the physician's parameters for that, but the guidelines are usually this. To hold the medication if the infant's heart rate is less than 90 to 110 beats per minute, or for children if the heart rate is less than 70, or for adults if the heart rate is less than 60. Also watch potassium levels. A low potassium level, hypokalemia, can increase digoxin toxicity. So a lot of times these patients may be on diuretics like Lasix that waste potassium. So you really got to monitor those potassium levels. Make sure they're getting enough potassium because it can lead to digoxin toxicity. Normal level, your therapeutic level is 0.5 to 2 nanograms per milliliter. We'll be measuring that. Also, in your infants, you want to watch that heart rhythm. One of the early signs and symptoms of digitoxicity in an infant is a dysrhythmia. So watching that heart rhythm, that EKG. Also watching for vomiting. And the antidote for digoxin is Digibine. Other meds that can be prescribed are like diuretics. And what diuretics do is that they will help pull fluid, extra fluid that's built up from the body, and the patient will urinate it out. But you have to watch because it can throw off electrolytes, and if they're on digoxin, what do you want to monitor? Potassium levels, because you can have digitoxicity. So we will be monitoring their I's and O's, making sure their renal function is good, they're not taking in too much and not really putting out. So you want to monitor that and monitor their weights, because that indicates if they're retaining fluid, because again, they're at risk for heart failure with this condition. Another drugs they can prescribe are ACE inhibitors, and what these will do is lower the blood pressure. When you lower the blood pressure, that's going to lower the pressure in this left ventricle, which is great, right? Because if we lower the pressure in the left ventricle, what's going to happen? We're going to decrease that shunting of that blood from left to right, so we can get more blood flowing up through the body, which is where we need it, instead of going back to the lungs and congesting those lungs and stressing them out. So another thing, nursing-wise, we want to be thinking about their nutrition, because one of the big signs and symptoms that they're going to have is their growth can be affected because they are just so exhausted, they don't feel like eating. So sometimes they need supplements. They may have to have a feeding tube. You want to educate the parent about the importance of getting proper nutrition. As a nurse, you're going to be doing calorie counts, you're going to be weighing them, measuring them, seeing where they're at. Next, you want to be thinking about as a nurse is risk for infection. They're at risk for lung infections because the pulmonary hypertension going on, the congested lungs. So they need to make sure that they're getting those preventative vaccines to prevent any type of respiratory infection they're at risk for, and stay away from people who are sick. And the endocarditis. Sometimes they have to be prescribed antibiotics to prevent the endocarditis. And treatment, surgery. For the really large VSDs, they can have surgery where a patch is actually placed over this hole, and the tissue from the heart will actually grow over the patch and keep that patch in place. And sometimes a heart cath can be performed where they can go in and close the hole that way. Okay, so that wraps up this review over VSD. Thank you so much for watching. Don't forget to take the free quiz and to subscribe to our channel for more videos.